Friends, I am here to interview Dr. Prakash Deedwania from USA. He is one of the authority in the lipid disease, and I am going to ask him today how the cholesterol hypothesis is sort of still criticized at times. So what do you think is that? Is it true that still some papers or some authors are writing cholesterol is not the cause of atherosclerosis? Sir, what is your opinion about that?
I think the cholesterol hypothesis is way beyond being hypothesis. It's now well established, and I'll tell you there are 4 lines of evidences. We have evolutionary evidence that suggests clearly that people who live in forest, the hunter-gatherers we call them, or in the pre-saturated fat era did not have atherosclerosis. So we have that evolutionary evidence. Then we have now the data from some of the Mendelian randomization where people who cannot make cholesterol, they don't get the disease, and people who have other characteristics where they're high cholesterol, they get very high atherosclerotic burden. But more important than that is we have experimental evidence. So then in any animal model where we have fed cholesterol, even in the setting where animals don't get atherosclerosis, such as rabbits, we can produce atherosclerosis by feeding high cholesterol diet. And then we have experimental evidence also showing that higher the cholesterol, greater the atherosclerosis burden, or the plaque burden, if you will. We also have evidence from early studies that were done in Korean war veteran, the young people, 20 plus years of age people, who, when we had autopsy done on them, they had died of natural causes, accident, war-related deaths, and they already had atherosclerosis, and it was related to cholesterol deposits. In addition to that, we have evidence from the young studies that are done in children, followed for 20 years, that when the high cholesterol was high, then there was a progression of their atherosclerosis. Now, of course, those evidences are still, one can always argue about it, but clear evidence is that drugs that reduce LDL cholesterol, specifically when we talk about statins, they significantly not only reduce atherosclerosis burden, but more importantly, they reduce cardiovascular events, particularly ischemic events. Let me give you a few examples. So we have evolved into this area. Early on, we learned from the studies that were done to look at regression with what we call angiographic studies. And in those studies, we found that even though the atherosclerotic stenotic area was reduced minimally, 2 to 3 or 4%. However, the events were reduced by 80%. So that proven the fact that there is something else going on, and that's where the concept of stabilizing the plaque came. So that's what was going on, even though we could not see angiographically. And then subsequently we have evolved very rapidly, and we now have evidence both with pathology, but more importantly with clinical trials, that we have clear evidence that when we reduce LDL with statins particularly, that are, despite what the press or the bad press is somewhat, which is not based on facts, that we substantially reduce the risk of coronary heart disease related events. And now the fact is we have now series of trials that go beyond statin. And clearly, if we can and we need to, we can reduce the risk of events even further. So we showed in the Fourier trial, in which, of course, I was a PI for Indian cohort, and we have shown that lower the LDL, and we looked at the LDL down to 10 milligram per deciliter. The lowest was the risk of coronary events. So I think there is no reason for us.
No more. I think the cholesterol is the reality, and
absolutely.
We have to see that the cholesterol is controlled well, and we have now got the evolution of the management, and so it is no more, I think, should be hypothesized.
No, I think it's well proven.
It's well proven.
Yeah, it's a well proven.
Sir, how is your sort of a concept about primary and secondary prevention?
Yeah,
so many times, personally I feel that primary and secondary prevention is a very narrow or a very gray area.
So
so you think just a prevention is the right word? How do you?
Well, actually, I've written 2 books on this, so-called the Cardiology Clinics of North America, where I wrote, it's a continuum. There is really very rapid transition from primary to secondary prevention. If we talk about true prevention, we should be talking about primordial prevention. What we mean by primordial prevention is that we basically don't let the culprit happen. So in other words, if we make sure that our children in childhood do not have high cholesterol, they will never develop atherosclerosis. If we can do it, it's easier said than done because it's hard to remove the fats from the diet. So I think if one can be cognizant of the fact that primordial prevention will be the best strategy, as difficult as it seems to do, that will be true prevention. After that, when we talk about primary and secondary prevention, the terminology are used kind of to define certain distinction. Primary prevention means that somebody who has not had an event, so somebody who has not been diagnosed with coronary artery disease or atherosclerosis, if we use interventions there, then we call that as a primary prevention. On the other hand, if somebody has a positive treadmill, CT angiogram, or coronary artery calcium, and we treat them, some people can call it primary prevention because they have not had an event, but as far as I'm concerned, they already have the disease, so that is secondary prevention. Now, traditionally, the secondary prevention term is utilized mainly to define a group of patients who have already had an event, for example, myocardial infarction, be it non-STEMI or STEMI. Those patients are described in secondary prevention. So as far as I'm concerned, it's a continuum.
I know, suppose you see a person with the high lipids, the abnormal pathology, the biochemistry and all. Now, to categorize him like primary or a secondary, so you necessarily try to do some subclinical atherosclerotic, the investigation, or maybe some simple methods. Why I'm asking this, because very, very relevant for us in India, because we see, premature atherosclerotic disease not only in coronary, but in the other vascular tree also. For example, we see people with between the 30, 35 or maybe 40 years, almost 20 to 25% of patients, particularly the coronary artery disease, So if I could prevent it, like whatever, primordial is okay, we have gone beyond that, at least the primary prevention. Say if I get an abnormal lipid report, a person who has come for a routine checkup, at the age of 30, 32, and suppose if I find, abnormal lipid which may be borderline, may not be the level as per the guideline base. Because whatever we guideline recommendation, the ACC...
But talking about the guideline, let me freshen you.
Yeah.
So we just had the newest guideline that was just introduced last week. My friend Scott Grundy and many of my friends were on the guideline committee, and I convinced them that we should put South Asians cohort as a high risk. So being South Asian is already high risk.
It has been
in the guideline.
One of
it has
the
been
risk enhancers.
Exactly. And also in terms of what should we do, it is recommended that in high risk cohorts, generally one should start with statin therapy if they have abnormal LDL beyond the whatever limits we have described in there. So I think there is not a simple answer to your question.
Correct.
The most
I know, but I'm looking into. I understand. I went through that atherosclerotic. The cardiovascular disease enhancers. In that, the triglyceride more than 175 also is put as one of the enhancer. Because as you said, South Asians, particularly.
Well,
for example.
yeah. So I think.
So my point here, because what type of lipid abnormality what we see are little different than typical the Westerners. Like our problems time and again. Like I'm an intervention cardiologist. When we see a patient of ACS, acute MI, more than 50% of the patient they have LDL or even the total cholesterol, just a borderline, but they have high triglyceride, low HDL. They're typical triad.
So typical
how to tackle those aspects?
Right. So I could prevent it. So I think I will refer you to several studies that have been done, including the ancient study called ProCam. And all of these studies, as well as the other gem fibrosis study, they actually, and the Canadian cohort, they showed that triglyceride will have a lot more importance if there is simultaneous increase in LDL. It becomes highly atherogenic, as you know. If the triglycerides are there, they have atherogenic triad, then they have what we call small dense LDL. And I would recommend people not to worry about doing this different kind of lipid test. You can project. If somebody has high triglyceride, they by all means will have small dense LDL. So one doesn't need to get sort of confused by doing these expensive tests. I think it's very important to keep in mind that if family history in our Indian cohort plays a very important role. It has never been proven, but I would say in India it's very, very important. We have to do more research. But if we have a strong family history of premature coronary artery disease, premature coronary heart disease in Indian cohort, I would say, is 10 years younger than in Caucasian.
Yes, in Caucasian.
So I think for man having disease under 45 and for woman having a disease under 55, that will be considered premature.
Yeah.
And if you have persons like this, I would definitely strongly consider doing a lipid profile in them. And if there are any abnormalities, whether atherogenic dyslipidemia, which is a triad, as you mentioned, or high LDL by itself, I would consider intervention in them.
Yeah,
also, let me tell you that we should not be focused on coronary event. Lately, I've been getting calls and I've seen many patients, young patients having stroke.
Exactly.
Stroke is a very disabling consequence of atherosclerosis.
Correct.
And sometimes we don't realize, but imagine a 32 or 34-year-old recently married Indian subject who has a stroke. I saw patients like this when I was in Durban 25 years ago. That changed my thinking altogether.
So what is your recommendation? So suppose if I see a patient post-ACS or a post-procedure, maybe the intervention or maybe acute MI, now is LDL just a borderline, triglyceride is truly high.
What is borderline? My question is, what do you consider borderline?
What I'm saying, maybe about 80, 85, 90 LDL.
That's high, too high.
I agree. So now about the therapy, I'm saying pharmacotherapy. Are you going to consider beyond statin any other additional?
I would say,
how is your,
first and foremost, anybody with acute coronary syndrome should go on maximum tolerated statin. We generally will recommend them to be on Atorva 80 or Indian cohort. We can consider 40, but it's not evidence-based. Or, although there are no data with rosuvastatin in acute coronary syndrome per se, in a large prospectively randomized trial, you can consider 20 milligram of rosuvastatin. This is what we have defined in the guideline as what we call high-intensity statin therapy. And what high-intensity statin therapy is, any statin that can reduce 50% by 50% or more, and these are the only two statins that do it. Now, after we have exhausted that, the current guideline emphasizes that if you have exhausted, then LDL is still high. And for anybody with acute coronary syndrome or diabetes, it should be below 70 at least, and I'll get to how low we can go in a moment. But below 70 LDL should be achieved either by maximum tolerated statin, and if needed, adding ezetimibe, 10 milligram. Because the ezetimibe can further reduce by 15 to 18% LDL. So, both of those drugs are very well tolerated, despite bad publicity that has been there. I don't see any basis for that. Yes, few people will develop myalgia, but rhabdomyolysis is very rare unless patient has significant impaired renal function and levels of statins are very high. These were the other statins that are not around anymore. And in terms of the hepatic dysfunction, high-intensity statin we have shown in very good control trial. There is about 2% incidence. It's reversible. We have not seen a case of hepatic failure with high-intensity statin in last 10 years that I've given high-intensity statin to hundreds of thousands of patients.
But suppose you have used rosuvastatin 40 or Atorva 80 equivalent dose plus 10 milligram ezetimibe. Maybe you get into the LDL target maybe around 70 or maybe a little less than that, or maybe like after improve it, it has come up like the additional the benefit beyond that 70.
But the improve it is somewhat misleading trial. Let me correct you.
Okay.
In improve it, and I just gave this talk at a major CME program, and we were talking at American Heart Association. Improve it only showed benefit in diabetic patients.
Only diabetic.
You take the diabetic patient out, there was no benefit whatsoever. So improve it does not give a license
for diabetic individual.
Diabetic individual.
When you really recommend, because we are in India at least, me personally, a little strong advocate of getting something like a triple target. You get the LDL low, you get the maybe triglyceride also less, because like now even the ADA 2018 and the other guideline do tell us if the statin maximize, maybe ezetimibe used, but if the TG is more than 12.5 or HDL less than 35, there is an indication to use the triglyceride lowering therapy.
Yeah, but
so
the evidence
at least in India, we have been very forcefully doing that. You think are we doing the right thing?
No, the evidence is not in favor. The evidence just appeared last week in the study called Reduce It. And I'm going to show those data tomorrow, and my good friend John Chapman is going to show those data in the morning, and I'll talk in the landmark trials in the afternoon.
Okay.
But clearly, there is evidence only for one class of agent, and this is icosapentaene, which is a specific omega-3 preparation.
Okay.
And they have shown when you use it in proper dose, that's the key.
2 grams per day.
4 grams, 2 grams BID.
Okay.
Very high dose, and I
Yeah.
think people may say that I smell like a fish or whatever.
Yeah.
So it's not easy to it's not palatable. But if you use that, then we have seen dramatic reductions in all of the events, coronary event, cardiovascular death, across the board, 20% reduction. So that is the first trial that has shown. The fibrate trial, unfortunately, was not done properly. I'm not saying fibrates don't work, but all the trials have been negative because they were done improperly. For example, the field trial. Field trial, if you look at cardiovascular coronary events, they were reduced, but they include amputation. So this was the primary. So that didn't improve. You don't expect amputation to improve either. Then in terms of the core trial that we did, NIS trial, we didn't include the patient with high triglycerides specifically. So if you don't include the patient who are the target of therapy, then you're not going to get the benefit. So we don't have the answer to your question specifically. I would say, yes, case by case, one can consider using good fibrate like fenofibrate in addition to
we have
statin.
been using, particularly in a diabetic individual, because in diabetic individual, this type of, the abnormality, like what we call it's not like a hyperlipidemia, but a dyslipidemia.
Yeah, atherogenic
dyslipidemia.
Yeah.
And therefore, our observation, at least the figure, it does have an effect of, triglyceride lowering, and the HDL comes up a little bit because
but
it is a mechanism.
Well, we had a talk this morning by my good friend John Chapman on HDL. HDL coming up doesn't mean anything.
No, but indirectly, you are looking into the pathology of, why HDL is coming low in our substrate.
HDL goes up because it goes inversely. If you reduce triglyceride, HDL will go up because these are two inversely related.
That's what I'm saying.
They are interrelated. But
so you don't recommend for being
I would have to individualize. There is no evidence for this kind of therapy. Yes, if somebody has high triglyceride, they have very high risk.
So you intervene at what triglyceride in the US or how would you?
I look at case by case. I would say if the triglycerides are higher than 200 with a strong family history,
then you
and I've used the maximum dose of statin still is the first line therapy. I would not do any of this without using a statin maximum tolerated dose. That still remains the first line therapy, primary or secondary prevention in these patients. In diabetic patients, you may be or you may not be aware, the STENO2 trial, which is the best trial, very small number of patients, but showed clearly there was a better than 50% reduction in these hard events, MI and death. And this 70% of this benefit was attributed to statin therapy, even though they did multifactorial intervention. So statin therapy is the standard for all these patients.
Final question for you. Now with the advent of PCSK inhibitor, you think now since all these trial, 4-year trial and the other trial have shown the safety of LDL even 20-25.
Oh, safety is not a concern at all.
Not a concern. So you think now with the coming up of PCSK, even for us in India now it's available for the last few months. You
but
think
the cost,
LDL
cost is
okay,
the main
but
consideration.
I agree, but there are some patients who can still What I'm saying you think our LDL target will go down, like if you have to see LDL mild to moderate risk less than 100, say high risk is 70, very high risk 50. Even our Lipid Association of India, which is also supported by ESC and other guidelines. But now you think with the PCSK, now we are in the process with CSI as well as the Lipid Association in India in another couple of months, going to have one more category after the high risk, extremely high risk.
Right.
Like people, like a CKD.
That has been already defined.
So we are trying to get up to 40.
Yeah, so that has been.
So you think it is?
I don't know about that. I won't go that far. I would say that American Association of Clinical Endocrinologists have already described this extreme high risk category. And they suggest that in extreme high risk category, based on expert opinion, no evidence that LDL should be below 50. And I would say expert opinion, emphasize it. However, in 4-year trial, we have shown
safety of
lower the LDL, fewer the events. So I think there is indirect evidence. And again, I suggest indirect evidence. That does not make the guideline, but individualization is the key. So and I have just presented, we have yet not published the paper, I just presented the data at the most recent ESC in the late breaking trial, showing within the 4-year trial, 16,000 patients with metabolic syndrome. They have a profile like what you're saying, the atherogenic dyslipidemia, that reducing LDL in them could be substantially benefit and provide greater benefit than those who did not have metabolic syndrome. So I think clearly we have data emerging, and perhaps future trials will show. But yes, if LDL is not controlled by what we have discussed, PCSK9 inhibitors are a very, very good solution. If they were to be cheap, then we can use it more liberally.
Thank you, sir. I think you have cleared many doubt on the lipid management. I'm thankful to you.
Thank you. It's a pleasure.